Welcome everyone, and thank you for attending today's Healthcare Finance webinar, Pinpointing Revenue Risk and Opportunity Across the Hospital Enterprise, sponsored by MediAnalytics. During this webinar, the presenters will share their perspectives into how organizations can leverage analytics to navigate changes in reimbursement. You'll understand how executive-level insight across the enterprise helps uncover revenue risks and opportunities from a single big-picture view of your data. I'd now like to turn things over to today's moderator, John Hansel, VP of Healthcare Provider Solutions at MediAnalytics.
Great. Thank you very much, Eric. And I want to say thank you also to Healthcare Finance for hosting this webinar. I believe we have a pretty big group on the call today, people from all over the country, and I just want to say I also really appreciate everyone taking the time out of their busy day to join us on this session. As Eric said, the topic today is really about using data analytics to improve revenue integrity for hospital organizations. And we're going to talk for a while about the importance of pinpointing revenue risk and revenue improvement opportunities throughout the mid-cycle, really, of the rev cycle. And we're going to try to understand how clinical activity, documentation, and coding really impact revenue and reimbursement. And to do so, we have a great lineup of speakers for today, really representing a pretty broad perspective on this topic, including a hospital CFO who's going to share her own experience using data analytics, much like this, to support her own CDI and ICD-10 initiatives at her hospital. So without further ado, let me introduce some of the speakers today. First of all, my name is John Hansel. I'm the VP of Healthcare Analytics here at MediAnalytics. I'm going to be the moderator for the webinar today, but I'll also be presenting at the end some real-world examples of analytics and revenue integrity dashboards and drill into some of the details with some example reports and analysis. But our first speaker today will be Drew Zeck from the Advisory Board Company. As you probably know, the Advisory Board is a renowned healthcare consulting, research, and solutions firm with a membership including thousands of hospitals across the country. Drew is a senior director in the Advisory Board's Margin Solutions Division, and he specializes in the intersection of clinical care and financial performance. And Drew is going to be sharing his perspective on what the Advisory Board has dubbed the mid-cycle, and we'll get into more depth on what the mid-cycle is. And then our second speaker today is Amy Floria, who's the Chief Financial Officer for IU Goshen Hospital in Indiana. Goshen Hospital is a member of Indiana University Health, and as their CFO, Amy is responsible for seeing all the finances and strategic planning for the organization. During this presentation, Amy is going to be sharing how she utilizes data analytics to support their CDI and ICD-10 initiatives, and also to drive conversations with physicians about clinical documentation and reimbursement. So welcome to Amy and Drew, and thanks for your participation.
Thanks for having us.
Absolutely. Really quickly, I just wanted to give the group an idea of the agenda over the next 45 minutes or so. We're going to start off with Drew from the Advisory Board, really providing his industry perspective and talking about some of the challenges in the mid-cycle. Then we're going to turn it over to Amy. She's going to share her experiences as the CFO at IU Goshen Hospital. And then it's going to come back to me, and I'll be showing some very specific examples of dashboards and analytics that can be utilized on a daily basis to improve revenue integrity. And then we should have about 10 minutes at the end to take questions and talk through some answers with the group. Then we'll wrap up about 50 minutes from now. So with that, I'm actually going to hand this over to Drew after I do just a quick overview and maybe provide a high-level industry perspective on how this topic fits into the broader trends. There's been a lot of talk recently about the transition from fee-for-service to fee-for-value, and discussion of all the new reimbursement models around accountable care, around bundled payments, capitation. This chart that you see here on the screen really helps to visualize that transition away from fee-for-service over the next 10 years. And probably every organization that I've spoken with, at least, is really at a different point along this journey. Everyone's got some sort of roadmap to manage their transition, their reimbursement cycle, if you will, away from fee-for-service towards fee-for-value. But the one thing that I hear consistently, and the one thing that seems certain, is that no matter what, financial outcomes are increasingly tied to clinical activity and clinical documentation. So when you add in ICD-10 on top of that, computer-assisted coding, RAC audits, value-based purchasing, you can start to see how this concept of converting care to cash will continue to be even more critical as a competency for hospital organizations going forward, regardless of how the transition goes from fee-for-service to fee-for-value. So on that note, let me hand it over to Drew to provide the advisory board perspective on the mid-cycle. So Drew, you can go ahead and take it from here.
Great. Thanks, John, and good afternoon, everybody. I'll echo John in thanking you for joining us today, and very excited to be speaking with you about a topic that's near and dear to my heart, the mid-cycle of the revenue cycle. And it is one of those areas that the advisory board is getting really bombarded with questions on from our members all the time, and is doing an increasing amount of work in day after day. It's probably the #1 focus for our revenue cycle executives right now, and for today's time I wanted to give you a little bit of this perspective of what the advisory board has seen across the country through the eyes of our members, and I'll share a number of different high-level anecdotes and challenges that we're seeing across the industry before handing it over to Amy to talk about some of the ways that she has worked with us at the advisory board really in a best-in-class way to get on top of these challenges. So I guess the conversation really begins with, why is the mid-cycle such a hot area of focus right now? And in addition to some of the big macroeconomic trends that John was talking about, we're really hearing 3 major reasons why our chief revenue officer constituents are focusing on the mid-cycle. The first is that largely there are systems and processes in place that exist within patient access and business office to measure the impact that your efforts are having far more accurately and discreetly than currently exist in the mid-cycle. And so as our chief revenue officers are being held accountable to certain metrics and outcomes related to revenues at their organizations, mid-cycle is one of those areas that we frequently hear they're scratching their heads on, how are we doing? So that's the first thing. The second thing that we keep hearing is that there's just a huge amount of revenue variability that's driven by the mid-cycle, and it's going to be increasing as we go forward. We'll talk about some statistics there in a second. And then the third is that the mid-cycle, probably more than any other piece of the revenue cycle right now, is changing the rules. They are seeing impacts from ICD-10 if we get there. They're seeing a huge increase in audits. And as John was alluding to, as reimbursement schemas are changing across the country, a huge piece of that is value-based reimbursement, where they're being held financially accountable to all sorts of quality metrics. So if we're defining the mid-cycle as all of those areas that impact the coding and documentation on an actual piece of care, including, unfortunately, all of those post-payment pieces where auditors might come back in and analyze, was this payment made correctly? There's no really surprise why the mid-cycle is such a hot area of focus. Now, what we are seeing that's a little bit counterintuitive is this level of focus in the mid-cycle despite a huge amount of investment that's already been made. All of the executives that I work with hands-on are sharing with us that this is not maybe a new area of focus. It's something that they're really doubling down on. In the past few years, we've seen, of course, goes without saying, an explosion in EMR, but we've also seen an explosion in CDI workflow tools, an explosion in computer-assisted coding tools. I think one of the statistics that I heard was that about 2,000 hospitals implemented or are implementing some form of computer-assisted coding in the last 24 months, which is just absolutely mind-blowing when you think about the dollars that are involved in a system like that and the implementation effort that's involved with a system like that. And then in addition to that, most of the organizations that we work with right now have some sort of compliance or audit tracking software. And I was talking with a good friend of mine who's the vice president of revenue cycle at a large academic medical center, and asking her, what is it about the mid-cycle that's keeping you up at night right now? It's kind of that quintessential advisory board question that we ask. And she said, well, Andrew, let me put it to you this way. I have a CDI team full of incredibly highly motivated, successful, and highly paid professionals who are auditing and querying and teaching physicians day in and day out. And their CDI workflow tool tells me that they have actually seen an $11 million revenue impact this year. But at the same time that that happened, my CMI shrank. Now, I don't know what to make of that. I see the work they're doing every day. I see the value that it has. But when 2 different tools are telling me 2 different things, it's hard to make sense of whether I'm doing a good job or a bad job. And meanwhile, my DNFB has gone up, so we're clearly spending more time on this type of mid-cycle exercise. And then finally, as kind of the third piece of the pie, the ADRs that we're seeing, or those additional documentation requests from auditors, have increased about 10 to 15% this year. Now, all of these things are clearly related, and yet most of the organizations that I speak with are sharing frustration that it's really difficult to understand when these tools and processes and individuals and departments are siloed, how am I doing across the board? So we've shared with you on the slide here at the bottom some of the pluses and minuses that we're hearing from our membership, the technologies that are in place, and oftentimes the processes that follow those technologies are very good as discrete workflow platforms. They are very strong with task organization, and they do, by and large, have good retrospective reporting capabilities. So just to pick on CDI for a little while longer, very easy to see what is my query rate, how many of those queries resulted in a DRG reassignment, and how often are my physicians responding. What is much harder to see is what is the global overall impact that that CDI program is having on my organization when you balance out some of the audit risk or things of that nature that might be unintended consequences of the program. So that's kind of the frustration that we're hearing from our membership. And when you look at the different slice of the economic picture that John was talking about before, it's no question why that level of uncertainty and that inability to accurately have performance metrics is something that's concerning to our members. If you look at, for those of you who listen in on advisory board presentations, you know we love this average 250-bed hospital that is everybody and nobody at the same time. But if you look at this average 250-bed hospital, they would be seeing about $400,000 in net denials write-offs every year just from documentation, not to mention front-end or technical denials. About $2.1 million in under-documentation related under-reimbursement, as well as about $100,000 in post-payment takebacks. And if you were to try to quantify the additional pain that they're feeling because of things like just lower acuity, worse quality metrics, et cetera, it would be even harder to quantify all of that loss. And when you look at some of the things that are happening in the future, first on the right-hand side of this page, annual rack takebacks. I remember all of the buzz about this back in 2008 during and just after the demonstration project. Well, at that time, CMS said they were expecting about $4 billion in rack takebacks, and 6 years later, they're finally getting to that number. And the number of dollars tied up in appeal, et cetera, has been exponentially increasing year over year. So all things considered, if you were to fast forward to 2016, what we're hearing from our members is that same 250-bed hospital that was facing $2.6 million in mid-cycle risk and loss is actually potentially facing somewhere between $5 and $11 million of mid-cycle loss, not to mention the cash flow tie-ups, the rework concerns, all of their efficiency problems that they're facing. So this is the reason why it's a big area of focus, and I think probably one of the reasons why at this very moment, and I always say that our members kind of speak with their feet and speak with their cash, we're working on something like over 550 active engagements that are related to the mid-cycle. So clearly a big industry challenge at the moment, and one that our members are facing acutely. So what, Drew? Okay, get to the point, and where should we focus? Well, before we turn the page to the solutions, I do want to get a little bit more specific with the problem that our members are seeing. And I'll share a few different anecdotes from members that I've worked with just in the last year or so. So 3 challenges that are being communicated to us. Number 1, lack of visibility. Number 2, lack of actionable insights. And number 3, striking the wrong balance. And let me tell you what I mean by these. So lack of visibility. An organization that I work with, about 500 beds, I was talking with their CFO and saying, well, how's clinical documentation improvement going? What are you guys doing? And she says, well, it's going well. We've got 6 CDI auditors. I feel like we forged good physician relationships. Query response rates are up, and we made $3 million off of CDI last year. And I said, so is that good? And she said, you know, to be honest with you, I don't know. And I think that that's what we're hearing over and over again is $3 million good? Is $5 million good? What should we be aiming for here? And there's a real challenge trying to figure out what is the opportunity that I'm facing and how am I executing against that opportunity. Same type of issue on the right-hand side, actually the exact same organization. I was talking with their chief compliance officer, and he was telling me, yeah, we got audited quite a bit actually this year, and we faced about $2.5 million that were tied up in post-payment audit takebacks across a variety of different payers. But, you know, we were 50% successful with our appeals, and he was actually a little bit more transparent with his feedback, which was, I have no idea whether that's good or bad. Should I be getting audited $3 million and winning 75% of the time, or what does success actually look like? And then when you take these two metrics, the left-hand side with CDI efforts, the right-hand side with post-payment audit efforts, what was totally missing from this equation was how are these impacting each other? And we're not sure, but I'll tell you the auditors are looking at that through a very fine lens. And so our members are asking for the ability to have that visibility into their performance increasingly. The next example that I'll share with you to bring to light this lack of actionable insight problem are two different things. One goes back to the CDI challenge. We were talking with the CDI team, and they were worried, actually, that their CC-MCC capture rate was decreasing, and they wanted to know why. And they wanted to know which physicians were responsible and what they should do about it. Well, on the right-hand side of the page, they really struggled, and we worked with them in quite a bit of detail to figure out, okay, what is our strategy to review charts, figure out what is the documentation that we're missing here, what should we be querying for, and largely, what should we be educating our physicians on? And at the end of the day, this was taking up weeks and hours trying to figure out what was wrong. And what they needed, and what we'll get to here in a second, is a number of different data points, like what are the specific secondary diagnoses that we're missing? What are actually not the codes that they're missing, but what are the concepts that they need to learn? And which physicians are missing those codes, and who are the few that are going to have the greatest impact? Similarly, on the compliance side of the page, another group winning 40% of their RAC audit appeals, what they really needed to know in order to push that audit appeal rate up was why are audits occurring, which claims present future risk, and what are other commercial post-payment audit exposures if we're getting audited like this by the RACs. To get to the bottom of that, this group had to they were just kind of caught spinning their tails, or chasing their tails, rather. They were only taking action when audit letters were received. They were focusing on tracking, not prevention. And what we finally went in and diagnosed for them is that they needed to be focused more on where has national and historical audit experience told us the auditors are going to focus. Before they focus there, what are the auditors actually looking for, and how can we proactively get ahead of those areas of audit risk to make sure that we are coding and documenting 100% appropriately so that we have a very high degree of confidence that we're going to win when the auditors come knocking at our doors. Final example, and then would love to talk less about the problems and more about the solutions, is this striking the wrong balance. This is a really humorous story, and the organizations involved actually allowed us to use their names for the purposes of this webinar. Tenet Health System and Vanguard Health System. On the left-hand side of the equation, we had Vanguard Health System, who we talked with extensively about what they were doing to increase their CMI. They were taking the stance of, we want more reimbursement, we want better quality scores, and we're willing to hold on to a claim until all queries are answered, and we feel like we are 100% spot on that the quality is right. On the right-hand side of the equation, we had Tenet Healthcare. Tenet was a large health system based out of Texas. They told us speed and cash flow are really of the essence here, and yes, we want to be aggressive with our querying. We want to make sure that we're really accurately billing for the care we provided, but if it's not here in 6 days, we got to get that bill out the door, and that is the rule that we live by. It was their Bible. And so we kind of scratched our head and said, well, actually, Tenet is purchasing Vanguard or merging with Vanguard this year. I wonder what Vanguard now thinks about that Tenet rule. And we went back and talked with the team at Vanguard, and they said, what do you mean the 6-day rule? We have no idea what you're talking about. And it kind of brought several things to light. First of all, they're going through a merger, and that's tough, but they probably need to talk about what is our stance going to be on when we're sending these bills out the door and what level of querying is appropriate. But it also meant that they needed to have some sort of data-driven decision-making process for at what point is it no longer worth launching another query, either financially or from a quality perspective, and we need to get this bill out the door, versus when does it make sense to hold on to that bill a little bit further, or in what areas is that actually driving an appreciable increase in our reimbursement and CMI? Or put another way, at what percentage of our DNFB are we comfortable having exist as DNFC, or discharge not final coded? So several different ways of illustrating this problem that's out there, but I do think that it's a huge area of focus for our membership right now. All of our members want to do three things: get paid properly, 100% of the revenue that they are owed for the care they provide, but not $1 more. Number two, make sure that those dollars stay in-house and don't get clawed back after the fact. and number 3, making sure that they're operating as efficiently as possible. So very excited now to actually hand it over to Amy Floria, who is a longtime member of the advisory board and someone we've worked with across a number of different initiatives to talk about some of the innovative ways that IU Goshen is getting this right. So thank you very much, Amy, for joining us today.
Thanks, Drew. It's great to be here and break away from my normal duties and spend some time this afternoon to talk to you about how Goshen has really put to practice some of the elements that Drew has explained already. As you can see on the slide, we are a smaller facility located in Goshen, Indiana, which is the northern part of the state. We are a member of Indiana University and have been since around 2000, so almost 15 years now. What we've been able to accomplish is really looking at our ICD infrastructure. And we established it back in 2011, and we started from ground zero. We had nothing. We stole a specialist and recruited her away from a competitor, and we really turned the reins over to her to develop the program we have today, which we now have 2 specialists. Our original specialist did leave us. I believe she works with the advisory board now. And she got us off the ground, though, to where our current specialists have really taken the program to that next level, especially working with our physician advisor to really look at the relationship we have and to resolve some of the issues we have with our medical staff. The process really for us includes a lot of hands-on support with our physicians. Our specialists are on the floor. They don't sit in an office. They are tracking down our providers. They do a lot of concurrent chart reviews, and they do a lot of one-on-one education. So they are taking specific examples to the providers and discussing the case with them and getting a better understanding of what the providers are thinking when they're documenting and giving a little bit more advice or guidance on not putting words in their mouth, but helping them understand how the words we select very much impact the coding and then, of course, the reimbursement we get. Technology has always been a real integral part of our CDI. I think you can get bogged down in a lot of the detail by being involved in the manual review of charts, especially with some of the data analysis we've done. Digging into our chart and some of our claims, we've been able to look at some very specific opportunities to improve the documentation and then educate our physicians accordingly. But we also ask the specialists what they want to hear and what they want to learn about, as well as really sharing with them some of the audit-targeted areas that we've gotten from third parties when they come in and do that clawbacks. We also look at monitoring unspecified code use and then also the CC and MCC capture rate to be able to pinpoint where we need to look at. Based on those elements, we really have tried to put into place the ability to prioritize our efforts. Like I said, we're a smaller facility. We have 2 specialists and only 2. I envy those who have 6 and 7. If we had 6 or 7, I think we'd be able to review each chart twice. However, what we've done is we've really tried to focus in on some of our bigger risk areas we've identified through our own data to look at where our ICD-10 revenue challenges are. But also, we really try to enforce and emphasize the CDI effort and documentation efforts are not just for an I-10 world, but it is helpful for us in an I-9 world as well to be able to continue to capture revenue appropriately regardless of what code is being assigned in our medical records or HIM department. So we really based our selection of the 4 areas, the hospitalists, intensivists, cardiologists, and general surgeons, by again looking at the quantitative analysis on our own data and really decided to focus on these 4 groups specifically to be able to utilize our limited resources in the most effective manner that we can actually use them. And really what we were able to do is we were able to really take those next steps and to figure out how to teach these physicians. We don't need them to become coders, but we also want them to be aware of what the basic elements can be when we look at documentation and look at how their words truly do matter. One way we have been able to educate our physicians, we really try again to get them not to worry about the codes. Some of our providers, I think, like to dazzle us with their coding knowledge and try to ramble off the codes they think should be included or what would be appropriate for the case that they're dealing with. But really, we just want them to get familiar with the concepts and what we need to document to be able to get that full reimbursement. And really it translates into being able to report the level of care and the quality of care that we actually are providing to our patients. We do use an advisory board product, ICD Compass, to be able to use this concept library and to be able to identify the concepts that we really need the physicians to add. Again, not just for I-9 world, but also taking that next step and being sneaky and how we are trying to educate and train our providers in the ability to operate effectively in an I-10 world that maybe or hopefully will occur yet this year. Really, the concept library also shows codes for the I-9 environment, for example, for chest pain. And then it's like a crosswalk or a bridge to be able to look at the corresponding codes under an I-10 world. And it really helps the physicians to point out specifically that additional specificity that will need to be documented to be able to support that greater specificity that's required in those I-10 codes. We also use this concept library to help us look at and monitor the CCs and MCC capture rates. And so we're able to go back to this concept library too, based on those capture rates, to be able to pinpoint some of the areas in the providers that we need to provide some really direct one-on-one physician education to be able to pinpoint those problem areas that we have. When you look at some of the individual attention that we do provide, and since we are smaller, there are fewer places for our providers to hide, and our ladies, those two specialists, are quickly learning where providers do like to hide. They meet really with the providers, again, on a one-on-one basis, and they provide them specific cases or patients that they have taken care of, and looking at their own individual documentation, and try to provide them some real specific areas through that chart review to help them get a better understanding of, we're not trying to tell them how to take care of that patient, but we're trying to get them to tie the pieces together. So you are tying in the test results with the why you ordered a test and what type of a diagnosis, and ruling out maybe conditions present on admission. So we're really trying to take that very specific evidence that we have for our providers and showing them specifically how they can provide a better and clearer picture of the care they're providing and why they're doing what they're doing. Because as we know, when we get those callbacks or those audits, if it's not specifically spelled out in the medical record, it didn't occur. And so you really don't get what you might say credit for that based on the DRG or the coding that you actually specified when you filed that claim. The other important part we have, I think, with our providers is that we really provide ongoing support. So we're constantly checking in with them. We have educational opportunities as far as going to surgical section meetings. Our specialists go to those every month and bring new cases, 2 or 3 cases, to be able to show specifically what's occurred in our 4 walls, to show them how it could be maybe fine-tune some of the documentation and provide them that ongoing support to see why we're doing what we're doing and how it does benefit them. And again, we try to stress that it's not just about the financial pieces and mitigating losses that we're looking against, but we're also making sure that it's impacting the visual quality measures that are becoming more and more available. We also try to prevent documentation problems in the first place, so we're trying to be proactive, just not reactive to the symptoms we see that are in the charts and from poor documentation. We really try to update our standard queries to make sure that we are including the concepts. So for example, if we have a query about heart disease, for example, or chest pain that's presented here, we'll change that query form if we're starting to see a trend in the questions that we're asking, just again to make it as easy as possible on our providers so the query process is not too intrusive into them taking care of patients. But we'll start to add the concepts for I-10 as well for determining the type of vessel, for example, again in the chest pain situation described here, but whether or not it was a source of the graph, whether the patient had any transplant, or whether there were any additional symptoms upon admission. So again, trying to incorporate as easily as possible without being too intrusive into their workflow, exactly querying to protect against those future losses that we don't want to see occur, and then also responding to some of the problems that we have a history of making and trying to correct those going forward to mitigate some of those losses. We've been fairly successful, I would like to say, keeping in mind that we have only 2 specialists, and back in 2011 when we really started to ramp this up, and 2012 when we finally got a program up and running, to come from nothing for me as a CFO, here you can see the results we've seen since August. I looked at a full 12-month calendar year, and we've really seen an impact of over $500,000 of positive improvement, and that is based on the actual charts that our specialists are able to review, and they actually manually track the improvements that they see in DRG selection and that type of thing. We also track our response rates from providers, and we zero in on those providers who may be hiding in new places that we don't know about. We get our chief medical officer involved to be able to talk with those providers if we continue to have some resistance from them, to try to get them more engaged and explain to them why they're getting these queries from these two ladies and why we keep harassing them politely, of course, to answer some of this documentation. It's really a great growth. We only saw about $300,000 worth of improvement in 2013. So we're seeing a really good ROI on the investments we have made. Of course, I too don't know if that $500,000 over the last year is as good as it can get. We need to figure out exactly how big of a pie we are trying to dissect, but at least for our first 2 years, and again, having only 2 specialists, I'm really happy to see the types of improvements that these elements and this program has really been able to generate, from going from 0 to no program to a program that I'd like to say is mature, but by all means we have plenty of growth to continue, especially as we get into and approach the I-10 environment. Now I'll turn it over to John so he can talk about, how successful our program has been because of data analytics. We can't do any of this without being able to take that data and actually put it into information and be able to share that with our providers. So I'll let John continue the story.
That's great. Thank you, Amy and Drew. You guys have brought up so many different topics and different potential areas to do data analytics that I'm going to try to hit on some of those and actually show basically some real-world examples using the underlying analytics technology from Medi-Analytics that's supporting a lot of the initiative that Drew and Amy described. I'm going to bring up some example dashboards. In fact, I have, you can see here, 6 specific examples that I think actually resonate with everything that you were just presenting. In terms of example 1, we're going to talk about the big picture. Drew was talking earlier about how one of the CFOs that he spoke with didn't really have a good way to understand how all of those pieces were fitting together across the enterprise. I heard both Drew and Amy mention CC, MCC capture and drilling down into case mix implications. Drew talked about the compliance audit risk and being proactive with compliance analysis. Obviously, the ICD-10 documentation concepts is a big part of this. We talked about the impact on revenue cycle metrics, on DNFB, on denials, on things that happen down the road in the revenue cycle. And probably most importantly, in the last example, I'm going to show how all of that fits together. How do you look at compliance, ICD-10, CMI, CC-MCC capture, revenue cycle metrics, all in one view from a physician perspective? So the first one I was going to focus on is kind of the big picture. It may be a little bit hard to see all of the details in these screenshots, but it should give you a sense of what an enterprise revenue integrity dashboard might look like and some of the key metrics and categories that can be rolled up to give that big picture view for a CFO or an executive that's worried about revenue integrity in all of these different areas. So you can see here, this is an example of an executive level view looking at metrics related to documentation, related to coding, related to quality, related to compliance, and related to revenue. So you can see a mixture of case mix, CC, MCC capture, dual coding, ICD-10 metrics, coding delays, quality metrics like hospital-acquired conditions, audit appeal success rate like Drew was talking about from a compliance perspective, discharge not final coded dollars and days, pulling in data, claims data, remittance data, patient accounting data, compliance audit workflow data, and getting that all together in one place so that the executive team of an organization can see the big picture on how all the ways that clinical documentation and coding is impacting the revenue of the organization. And that's one of the sort of things that was lacking in one of Drew's earlier slides, was that holistic view. And this is an example, I would say, of that holistic view of revenue integrity across the enterprise. Now I was going to drill down and show you underneath this, every department, every physician, every focus area might have their own much more focused view. So the next example, the type of analysis that can be done to support these type of initiatives, is really from an inpatient basis, focusing on the CC, MCC capture, and really focusing on CMI, revenue opportunities, and risks. So what you're looking at here, just for those that can't quite read everything on the screen, is an analytical report looking at DRG groups. So these are MS-DRG groups. The first one, for example, is 291 through 293, all the MS-DRGs for heart failure and shock rolled up into a group. and we're looking at the case mix for that organization. We're comparing that to a cohort of peer organizations. So this might be a benchmark from, say, MedPAR Medicare data, or a benchmark of other MediAnalytics Advisory Board clients from last month, comparing the CMI for this particular cluster of DRGs, comparing the CC-MCC capture rate compared to that cohort. So in this example, this organization has a slightly lower CC-MCC capture rate for that particular grouping of DRGs. And this could be sorted for the highest impact DRG groups, or the biggest variances, the biggest opportunities, the biggest risks by DRG group. This is not a new analysis. This is something that many hospitals do today, although they may not use the benchmarks in such a granular way. Regional benchmarks, being able to filter out by bed size, whether it's an academic medical center, by specialty, etc. Probably the more interesting analysis is underneath this. When I click into these DRGs, underneath that is more of the why. So let's just pick one of the DRGs. Here we've picked on DRGs 329, 330, and 331, which are major small and large bowel procedures. We're just looking at my health system versus that cohort benchmark of 200-bed hospitals in the Southeast, for example. And you can see the distribution of how we are capturing MCCs, CCs, and without across, say, 500 claims over the past year, and how that compares to the cohort. And just very quickly and visually, we can see a difference of approximately 8% in terms of our MCC capture rate. So the driver behind that variation in case mix index is we're actually capturing CCs at approximately the same rate as our peers, but we're missing major complications and comorbidities at a rate of about 8% lower. So why is that? Which physicians are responsible for that? Or who's lacking the documentation? Or what parts of our organization, which facilities, and specifically, which codes? What are the secondary diagnosis codes that we are not capturing relative to our peers? So click into that, and one level below it is that code level benchmarking. And this is something that's not typically done in high-level CMI reports. This is getting down into those major complication and comorbidity secondary diagnosis codes for that same DRG to show, for example, that other hospitals in this cohort in the Southeast for DRG group 329 through 331 are capturing acute respiratory failure 5.8% of the time. But my organization only does it 3% of the time. Click, and I can see how that breaks down by physician. And some of these might be, patient safety indicators. Some of them might be MCCs that are driving CMI opportunity. But being able to get down to the code level, down to the physician level, is really how an analytical tool takes you down from just high-level CMI comparison down to where the rubber meets the road at the individual physician documentation level around specific codes that are driving that CMI opportunity. So that's just one inpatient example of how the analytical platform for MediAnalytics supports the CDI and CCMCC initiatives that Amy and Drew were referencing. Let me flip this a little bit and we'll talk about it because it's not just from an inpatient perspective. We have a lot of clients, hospital systems who own or are affiliated with large medical groups and physician practices, and a lot of the physicians in the room will ask us, well, what about E&M code distribution? What about the stuff that really directly impacts the money in my wallet? And this is another example of using analytics and benchmarking information to look at the sort of bell-shaped curve of E&M codes in different areas. This happens to be showing office consultations and inpatient consultations, but it could be any of the E&M code clusters to show variation by physician, by specialty, and understand maybe my organization or this group of physicians is utilizing a certain E&M code that's weighted higher or lower, more or less frequently than the average for that organization, or for the national average, or for the average for that specialty. And we can show visually the distribution variances and outliers by physician. Another great example, moving away from the kind of CDI and case mix, Drew had mentioned some of the risk around compliance and the increase in RAC audits and other types of government and payer audits sort of ramping up, and also the idea of being more proactive and using predictive analytics to understand where are the risk areas prior to getting audited. This is a great example of the specific report that underlies that concept. So this may be a little bit challenging to read, but you can see a series of risk target areas. So the one here at the bottom is review for 3-day skilled nursing facility qualifying admissions. This one says review billing for inpatient crossover to ER clinic visits. Review medical record for outpatient visit within 72 hours of inpatient admit. Times 300 or 400, every little target area that any hospital has ever been audited for by RAC, MIC, ZPIC, commercial payers over the last 5 years have been captured here in a predictive rules engine to say there's potential risk in all of these areas. This is how many claims and dollars are at risk, and here's how it breaks down by physician. So just another example, more from a compliance perspective, of how you can use an analytical platform to understand revenue integrity and revenue risk across the organization. The flip side of that, the compliance risk was often looking at overpayments, that you're at risk of getting takebacks. Similar rules engine from a revenue integrity perspective can be focused on underpayments or missing charges, essentially the idea of charge capture. Hundreds of predictive rules using data mining to show where we potentially missed charges, missed things. For example, we have a patient who received a flu vaccine, billed for the vaccine but not for the admin charge. It's simple stuff, but it adds up. A lot of this is outpatient focused, but it adds up to millions of dollars. And again, we can analyze that down at the physician level, at the facility level, at the specialty level to understand what are the top areas for potential missing charges or underpayments based on coding and documentation. Another great example, Amy talked a lot about this one, is the whole ICD-10 documentation concept analysis. This is what it actually looks like when we're doing analysis down at the physician level. So I've created a report here that shows 5 different physicians that are in orthopedic specialty. I can see how many claims they have at risk for essentially new documentation and additional complexity when they go from ICD-9 to ICD-10. And specifically, for each physician, I can expand it and see what are the top documentation concepts based on my claim activity over the past year or two. What are the top documentation concepts that I need to focus on, high priority under ICD-10? They're going to have the biggest reimbursement impact and the most new documentation concepts. So you can see things like type of disc disorder, stenosis site, type of joint disorder. Here's another example, same type of thing, bringing in data from the 835 to understand clinical denials. Again, if you could read this in detail, you'd see these are the EOB codes for clinical and coding related denials, analyzed down at the physician level and the dollars and denied amount associated with them. Just another viewpoint on how clinical documentation impacts reimbursement. This next example is more of a revenue cycle example that Drew had talked about this in terms of DNFB and billing delays and sort of the HIM coding delays. This is looking again by physician, by facility, looking at how many claims or accounts are held up in DNFB, not final coded or coded by physician. And really, all of this comes together in the concept of a physician-centric revenue integrity scorecard. So imagine every physician, every department, every specialty, and for the whole organization, but specifically at the physician level, you can share rich benchmarked information around everything from my CC documentation opportunities to my compliance audit risk, to my top 10 unspecified codes, to my ICD-10 documentation concepts, my charge capture opportunities, my E&M code distribution, my clinical and coding denials, my HIM billing delays. A lot of times those are very fragmented initiatives and fragmented reports across the organization. Pulling them together into one view and presenting them at the physician level is really how all of those different reports fit together into a unified concept. So to me, that's really the punchline of all those screenshots, is pulling all of this together, kind of getting that 360-degree view, if you will. And with that, I think we're going to wrap up. I know we have about 5 minutes left right now. I don't think I need to spend too much time on these key takeaways. what I was going to do was actually take that 5 minutes and make sure that we open it up for Q&A, and we have a number of questions that were typed into the WebEx, so I'm going to make sure that we address some of these questions in the last 5 minutes, and then we'll wrap up. So I'm going to direct most of these questions to you, Amy and Drew, so let me just scroll through them here, and I'll read. Maybe I'll start with this one for Amy. As a CFO, how do you collaborate with your chief medical officer or your clinical leadership? And do these CDI and ICD-10 reports help you kind of bridge that conversation between financial and clinical leadership? Maybe if you could just give us some perspective on that.
It definitely makes us talk to each other, and those conversations are not always easy to have. But it really does force us to look at the data, and I'm very fortunate to be able to work very closely with our chief medical officer. He's right down the hall for me, and he's always very willing to address specific examples if we're having discussions with providers or they're having lack of engagement or not participating quite at the level we want. But we've worked really well, I think, together, whether it's looking at the CDI program, whether it's ICD-10 education, but it's definitely been an opportunity for us to work better with the clinical staff when normally we kind of operate in two different silos. But this has been an opportunity to really bring our forces together to tackle this problem.
That's great. Maybe as a follow-up question to that, let me just ask you, do you, and this is for Amy, I mean, do you actually pull together a sort of a cross-functional team of folks across CDI and ICD-10 and clinical quality and revenue cycle? Do you have sort of an infrastructure in place to do these sort of cross-functional views of the organization?
We do. We're fortunate because we are small. We wear a lot of hats. And so at those 4 different committees, I attend most of them, and our CMO attends several of them as well. We have our care management teams involved in several of those committees as well. So we try to cross-pollinate as much information as we can, but we find similar faces at the table when we bring those 4 groups together, even individually. So we do have a lot of overlap, and it does help dovetail and really coordinate those efforts in all of those arenas.
That's great. The next question I guess I'll direct towards Drew. It's kind of specific, but the question is, how do denials play into this? And specifically, how do you recommend engaging physicians on some of those more revenue cycle metrics like DNFB or AR days or denials, the things that aren't so obviously clinical? How do you get them engaged in the kind of the revenue aspect of this conversation?
Yeah, it's a good question, and it does vary by organization. I think when we're advising on physician engagement, when I talk with a number of my peers who actually are physicians, one of the big things that they stress to me and to our physician members is that the purpose of the revenue cycle in the business office in many ways is to take a lot of the administrative burden of revenue management off the shoulders of the physicians. And so when we have conversations with physicians, they don't tend to be related directly to the revenue. A lot of times when introducing themselves in their role, CDI specialists or other specialists who are interacting with the physicians will certainly acknowledge the fact that there's a revenue component because the physicians know it already, and otherwise you might come across as trying to pull the wool over their eyes, which you don't want to do. But I think when we're talking with physicians, it's more about how are you actually getting credit for the care that you're providing, and what are the quality and acuity impacts on your cases if you're not documenting to the fullest extent required. And I do actually think that there have been a lot of really good changes in a lot of our physician interactions in the last 2 years, and physicians are starting to get it. And then, kind of on top of that, they really want to make a difference, and they really want to do the right thing. And so a lot of times it's really talking them through the concept and how that impacts their world and being a face and a real person with them. But I guess specific to the revenue cycle metrics, they're not usually things that we bring up with the physicians unless they're things like denials that are kind of directly attributable to them.
That's great. Thank you. I think one more question here. We have a specific question just about benchmarking. What are the sources of benchmarking data? And I guess I'll direct this to Drew. Sort of what are your recommendations about peer group benchmarking when it comes to, even for some of the examples that I showed around MCC capture and case mix and E&M coding, internal versus external benchmarks? I'm paraphrasing the question here, but could you speak on that topic?
Yeah, absolutely. And this is something we talk about constantly, so happy to also go in more detail offline. I can benchmark all day long. But I think the first thing that we would say is really many of our members do not like the MedPAR benchmarking. It's great because it has such a big sample size, but timeliness matters so much, especially since there's so much movement in clinical care and in coding and documentation these days. And so I guess the timeliness of the benchmark is the first thing that we address. But I think one of the real benefits of the solution that you showed, John, is the timeliness of the benchmarks. The second thing is that there's always this tendency to say, well, let's shrink the cohort that we're trying to benchmark against more and more and more and more because nobody's quite like me. And the reality is nobody's quite like anybody, but benchmarks are still really valuable in terms of comparing organizations. And so we always encourage our members to realize that they're more like their peers with those benchmarks than they might imagine. And then I do think it's also quite valuable. Those were, of course, examples of external benchmarks, internal benchmarks, just as important in kind of measuring people against each other and managing to certain expectations internally. So those are kind of sample size comments. I guess the final thing I might say is sometimes benchmarks are most valuable when they're very specific about a challenge. So, John, you mentioned some of those RAC risk rules or specific usage of secondary diagnoses, and these are very specific types of benchmarks, but they really help you hone in on what is the root cause of the challenge that I'm missing right now. And again, I thought that that's a really strong piece of what you were walking through because those benchmarks on those really nitty-gritty end root cause analysis type things are the ones that really help you solve those challenges at the end of the day and see the improvement you're looking for.
All right. Well, thank you very much. I'm sensitive to everyone's time. We're up against the top of the hour here. So I'm going to wrap up the Q&A here. We do have a few additional questions, but we will reach out directly to those of you that ask those questions and make sure that you get an answer. So thanks again for your time. Really appreciate it, and have a great day, everyone.